I type on this thing? Ah. Audrey, I see that you did sound check. I can't hear you. I don't know if you can hear me.
Loud and clear.
Oh, yay! Oh my God, I can't type on this thing. You want to send it? Yes. As a matter of fact.
I didn't have breakfast this morning, so I just have one.
Perfect. I would
How much
recommend,
salt did you put in it?
okay, I have no idea, so I didn't know.
What?
It's probably not healthy.
It's probably not very healthy.
Oh,
can guarantee
maybe I
that.
should.
Yeah, they're very gooey.
I didn't make them, which means they're not heart healthy.
So, but I can't imagine there's that much salt. It's
Well,
probably
you
just
would
a
be
pinch.
surprised.
Well, but it's homemade and it's sourdough.
Doesn't matter. Do you know how much salt's in a loaf of homemade bread?
How much? How much?
Angie?
Angie, how much?
There's 0 in mine because it's not actually needed.
Oh, I don't know that she would put a lot of salt. I could ask her. I don't know. I wonder if they know how to get that.
Who made these?
The case management
They
assistant.
smell good.
She's like a, look who it is. Daniel,
Oh,
did you come for the cinnamon rolls?
no, it didn't.
Sure. Yeah, I would definitely recommend microwaving it if you want to for a couple seconds. That was her. That was her.
Do you want to taste it first, Dad, and see?
Sorry, I couldn't be on earlier today.
Oh, you're fine. I'm doing that thing. You can walk in front of there if you want.
I don't.
You don't want to be on? Come on.
Not yet.
No, you're fine. We were just talking about we just went over the charting that we had already done before. You gonna need it up? Oh, yeah.
I'm gonna ask, one of those people. She said like 10 seconds is all you need.
I figured. Do you want a cinnamon roll?
Like,
Not made, but they are handmade. From a coworker that she was working with.
I'll see. Maybe at the end.
They didn't put arsenic in them, did they?
Okay, so we'll find out.
So there's normally like over 3,000 milligrams of sodium. And
Oh,
that's just with the salt.
that's a lot.
In most recipes, but like I make homemade bread and stuff for him at home, and I just don't add the salt, and I add some honey, raw honey to it, and it raises and everything just fine.
Salt usually retards raising, I mean, to some degree. So not having it would actually make it easier for the raising.
It turns out, you like it at home.
Yeah, so
And it's a
fresh
lot
bread at
healthier.
home is the best.
And it makes your house smell wonderful.
So good.
Yeah, and I make the rolls and stuff like for him at Thanksgiving and stuff.
Did you start that already?
Yeah. Yeah, I'm sorry.
Oh, and these
I
are,
think you can just push and then you can talk, so you can put them in different spots on the tables.
so if I do, Cindy, can you hear me? Yes, I can hear you now. Okay, very cool. We have these little speaker things that we're gonna put throughout, so if people have questions, they can unmute themselves. Oh, awesome, good. So I forgot that I'm virtual and probably nobody else is. So we're so used to having all of our meetings with everybody virtual that I was like, when are people gonna log in? But I forgot. I know, I mean, it's really. But we have one.
I unlocked the door for you.
Three, thank you. 3, 4, 5, 6 people, 7 counting myself in person, here to listen to your spiel. And we are recording it on YouTube Live via another computer because we are not that tech savvy. So other people do watch the recording later if they can't make it in person. And I have printed out your guys' handbook on understanding lung cancer screening to hand out for everybody. So I think probably maybe we give it another couple minutes when we get started. Not used to being here so early, it's only 1 minute after.
Yeah, that sounds great. I will tell you, it's a little hard to hear what you're, so if you ask me to do something, I can't. It sounds like you're a little further away.
Any better?
Take it further away.
Oh, whoever that is speaking, I can hear you very well.
That does not surprise me.
So she's on the other side of
So just,
the.
you be my director, you tell me what to do.
Oh,
There you go, the green.
So the green is on.
he handed them to me the other way that I
Oh.
said it.
Technically handy.
This is what I asked for help.
So you want to turn this on, you don't want her to hear.
Okay, how about everybody goes red for, so we don't accidentally interrupt her. Green means go.
Go.
I have been having this like intermittent insomnia thing. So I think I went to bed at like midnight 30-ish. And got up at 4. So.
I can tell.
Yeah.
I can taste some though.
Well, I've never eaten much salt because of my body doesn't.
I can taste it because I'm not a salt eater, like I don't like the taste of it.
I don't add salt either. I don't like it. I mean, I like some salt, but not that much.
Dude, I've never liked it, even as a kid, I can,
You're not a savory.
like, on my vegetables and stuff, my mom would put salt and butter on it, and I wouldn't eat them. So she would leave it
Plain one.
plain and not put any butter or salt on it.
Not even butter?
No, it's disgusting. Oh my gosh. Absolutely disgusting.
You guys want pens?
I think I do, because I didn't have one last.
I got one.
You got a pen?
Of course, I can always work with that.
I thought yours were for different, she's irrelevant.
It's not gonna be in. I can show you that.
These are my.
I got your phone number.
You do. That's funny. We were in the hospital. I had to go through my email to find out his phone number.
And you could have just looked through his phone. Okay, drop the phone. Lip gloss on your table. Go that chair. Doug, did you drop your lip gloss? Oh, did you drop your lip gloss?
Did you drop your lip gloss?
Not me,
No.
it's in my pocket. It's called chapstick. I don't go anywhere with that.
Especially not this time of year. That's pretty
I think it's,
coming through the.
I think someone's fan, maybe? She's unmuted. It's more in the world.
I think that's typing. That's someone typing.
Yeah, with the world.
Sounds like somebody's vacuuming or something weird.
Maybe it's above us. Is there anything above us?
Still haven't decided. A couple of different options that I'm still looking at.
All right, I think we can get going if you guys are ready.
Okay, yeah, that sounds good. I'm gonna share my screen. First, I don't know if you can see both of us on here, but I'll just introduce myself. And Angela here is moral support for me, but she's our policy guru too. So if there's any policy questions or anything like that, I'm so glad she's here. But I'm Cindy. I'm the clinical director of Lung Cancer Initiatives here at GO2. I'm a nurse. I've been a nurse for a little over 20 years, primarily oncology. I've done some trauma work in the past, some surgery, but was not my cup of tea, so I came back to oncology. I joined GO2 in January, and I am part of the Excellence in Healthcare Delivery team, so is Angela. I'm going to share my screen and get started here. I left plenty of time for question and answer, so I'll just go through the slide deck. It's a brief overview of what we do at GO2, what lung cancer is, the current state of lung cancer, what lung screening is, and kind of next steps should you decide that you want or you know somebody who needs a lung cancer screening, kind of what your next step should be after this meeting. And then at the end, feel free to ask me any questions you have. You can put in the chat or you can ask out loud. I'm not sure what your setup is there, but let me just start sharing that. And if you can't hear me or can't see something, please feel free to stop me. Because I can't see you while I'm presenting, so I can't see it if you raise your hand. Just unmute yourself and talk to me. Okay, so GO2 for Lung Cancer, we are the leading national nonprofit patient advocacy organization. We are committed to saving lives and improving outcomes for everyone affected by lung cancer. We drive progress through early detection, equitable access to quality care, patient empowerment, and meaningful policy change that addresses systemic and structural barriers. Our work places a special focus on historically marginalized and underrepresented communities, advancing health equity and justice at every level. Our vision is a world where everyone with lung cancer not only survives, but they thrive. And we'll talk about some resources that GO2 has towards the end of this talk. But a little bit about GO2, I wanted to include this slide just so you could see the breadth of the work that we do. Our work is driven by our 4 key goals that unite each of our departments across the organization. We increase the rate of lung cancers, by increasing the rate of lung cancers diagnosed at an early stage, an early, more curable stage, expanding access to comprehensive biomarker testing, strengthening the reach and the impact of community engagement, and improving quality of life for all of those affected by lung cancer. Each department, our advocacy and policy department, events, healthcare delivery, patient support, and our research department, we all play a vital role in advancing these goals. And through coordinated efforts, shared expertise, and aligned strategies, we ensure that policy changes fuel clinical progress, community engagement drives awareness, and research informs best practices, and patient-centered support remains at the heart of our mission. So I took it back to some very basic, what is lung cancer? I'm sure that most of you guys in the room either know what lung cancer is or you know somebody who's had lung cancer or been affected by it. But essentially, lung cancer begins when cells in the lungs start to grow and divide uncontrollably. Normally, our cells follow a very orderly cycle. They grow, they divide, and they die off at a pretty specific, steady rate. But when something changes the DNA in these cells, they can begin to mutate, and they multiply much faster than they can die off. And that normally results in the formation of a tumor or a mass. And this type of damage is often caused by toxic exposure, such as the chemicals found in cigarettes. But however, it can also result from other factors like radon gas, air pollution, or even a genetic predisposition that increases a person's susceptibility for lung cancer. For many people, especially those with a history of tobacco exposure, these risks can add up over time. So yes, it can be as simple as one factor, especially now as we've advanced and lung cancer has become more prevalent and people with younger age are being diagnosed. Some of those patients are simply a genetic predisposition. They have never been exposed to other toxic factors such as a tobacco history or a time in the military where they were exposed to other chemicals and whatnot. Theirs is truly a genetic issue. But for the most of the patients, these risk factors, it's not that simple. It's a compounded effect. So research shows that when lung nodules, especially whether they are detected through a lung cancer screening or through just an incidental imaging, when they are carefully tracked and when we know they're there and we watch them very carefully, that we find the lung cancer when it's super early and it's an earlier stage. And finding it early means more treatment options and a much greater chance of survival. So, sorry, my button's not working. So what is the current state of lung cancer? Lung cancer continues to be one of the most serious health concerns in our country. In 2025, it is expected to be the second most commonly diagnosed cancer among both men and women, but it remains the #1 cause of cancer-related deaths, taking more lives each year than breast cancer, prostate cancer, and colon cancer combined. And despite being the leading cause of cancer-related death, it is one of the most underfunded in research dollars. So these are some little handouts that we have at GoTo. On the lung cancer, the second one, lung cancer facts, where it talks about research dollars, we can see that these dollars are correlated with dollars per death. So for every one death in breast cancer, they have almost $20,000 dedicated to research. If you go all the way down to lung, that number is a lot less. So that's something that we do on our team, not our team, but in our organization, is advocate and fight for more lung cancer research funding. And we talked a little bit about this, but who is at risk? In a nutshell, if you have lungs, you can develop lung cancer. And while smoking remains, or tobacco history remains the leading cause, anyone can develop lung cancer. People who have no tobacco history, they still account for about 20% of lung cancer cases in the United States. Other risk factors include, a history of tobacco use or exposure to secondhand smoke, radon exposure, and we'll talk about that a little more in depth in just a minute. But occupational exposure, such as asbestos, diesel fuel, diesel exhaust, or certain chemicals, air pollution, and then a family history or genetic predisposition for lung cancer. And also previous radiation therapy to the chest. So if you've had treatment for another cancer as a child or earlier on in your life, that also increases your risk to develop lung cancer. But just remember that if you have lungs, you can develop lung cancer. That's the #1 rule I tell everybody. There's a lot of stigma and a lot of bad knowledge out there about lung cancer that, we've heard all the things from patients that when they tell people that they have lung cancer or they've been diagnosed, that the first question that's asked of them is, well, did you smoke? And yes, we know that tobacco exposure is the #1 cause, but there are so many other factors to consider when someone is diagnosed with lung cancer. So a lot of it about radon exposure. Just to note that radon is the #1 cause of lung cancer among non-tobacco users. And I did a little deep dive into the area that you guys live in because I was curious to know a little bit more about that. But radon, we know, is an odorless, colorless radioactive gas. And it's naturally emitted from the decay of uranium in the soil and the rocks. And it can seep into homes through the foundations, through cracks in the foundation, but it can also seep in even in newer builds, well-sealed homes. So it's not just the older homes that have foundational issues. That's what we kind of used to lean towards, but now we know that that's not always the case. And this gas, like I said, is now recognized as the second leading cause of lung cancer death in the U.S. after smoking. The United States Environmental Protection Agency, or the EPA, estimates that about 21,000 lung cancer deaths each year are attributed to radon exposure. And radioactive particles, this is kind of how it takes place. So radon seeps into the house, and those radioactive particles are inhaled and deposited into the lung tissue. And over time, they can trigger cell damage leading to that DNA damage and, the overproduction of damaged cells leading to lung cancer. So everyone that spends time in a building with an elevated radon level is at risk. But the risk is much higher for people who also have a history of tobacco exposure. Because as we talked about before, these factors work together and they compound on one another. And the EPA has designated, and I probably will say this wrong, is in Ada County as a zone 2 radon level. And in the state of Idaho, the radon risk is especially important because they know that many homes and buildings show an elevated radon levels. And the state geology contributes to that issue. Lots of uranium, lots of radium in the soil. And the fact that radon can, like I said, accumulate in even newer builds, it all kind of comes together for these increased radon levels. But it's worth noting that in Idaho, I found that about 1/3 or 33% or so of radon tests show levels at or above the EPA action level. While there's no safe level that's known, the EPA has put out a level that they recommend if your home is above this level, that you have some mitigation, some treatment to reduce that level. But what does this mean for you guys, especially if you have tobacco history? Like we said, radon exposure adds to your lung cancer risk, even if you aren't currently smoking. And if your home hasn't been tested for radon, now is a really good time to do so. Having both a smoking history and an elevated radon level can considerably increase your risk of lung cancer. Testing and mitigation are pretty feasible when it comes to, I know here in Alabama, we get on the EPA website, I believe that's the website you go to. They will actually send us a radon testing kit for free. I'm in Huntsville, Alabama, so I'm here near Redstone Arsenal and the Space Center. So we have a lot of issues here with radon, but I would recommend getting on your EPA website and just kind of seeing what can be done to test your home. And I have never had to do this, but I understand that mitigation for elevated radon risk is relatively inexpensive. So a little bit more about why we're here today. We wanted to talk about what lung cancer screening is. And screening is testing high-risk individuals with a low-dose CT scan. And when I say low dose, the radiation that you get from a lung cancer screening is about equivalent to what you would get from a mammogram for breast cancer detection. And the purpose of this, why we screen, is to identify these nodules when they're very small and they can be treated and your chance of a cure is much higher. And also these lung cancer screenings can detect other abnormalities in your lungs like COPD, other issues that you might need to see somebody to address. And like I said, finding a problem at an earlier stage before there are symptoms, before you even know that it's there, will make it easier to treat. Studies have shown that screening those that are high risk with a low-dose CT scan before symptoms can appear can find lung cancer early, like I said, but it's easier to treat and it's more likely to be cured. And in addition, lung cancer screening might also show if you have other conditions or diseases that might need to be treated, such as cardiac issues, thyroid issues. There are many other findings that can be detected on that lung cancer screening. Currently, the guidelines for lung cancer screening for a specific high-risk population is that you are at least 50 years of age, so 50 to 80 years, and you either are a current tobacco user or you have a history of tobacco use within the last 15 years. And in addition to those two factors, they want to know how much you smoke or how much you have smoked in the past. And we call that a pack year history. So there's a little formula that we do for that, but essentially it's a 20 pack year history, meaning either a pack a day for 20 years, 2 packs a day for 10 years, or some variation of that adds up to at least a 20 pack year history. So I wanted to add a little bit about lung cancer screening and where we stand today. We know that women screen for breast cancer, that men screen for prostate cancer, women and men screen for colorectal cancer. These guidelines and these screenings are fairly well known, and they're pretty well followed by people when they qualify. I think the last data that I looked on breast cancer screening is that out of the eligible population, about 75% of women who are eligible are actually getting their screening. When it comes to lung cancer screening, that's not the case. On average, some are better, some are worse, but on average, about 6% of the population that's eligible for lung cancer screening are actually going and getting those screenings. And there's many factors for that. I think that the highest one would be a lack of education. The patients don't know that it exists. The healthcare provider may not know that it exists, or if they do, they may not have the time to talk to their patients about it. There's a lot of mixed information about insurance coverage and whatnot. So there's many reasons why that is the case, and why Angela and I are here talking to you guys to try to spread the word about lung cancer screening. Widespread screening would prevent possibly thousands of deaths each year. It would reduce the burden of late-stage diagnosis, and it would improve the quality of life for countless individuals and their families. So part of what we do every day is ensuring that all of the people who qualify know about lung cancer screening, and we help them to increase access to lung cancer screening. And hopefully all of this work that we do and speaking to you guys can help change the trajectory for lung cancer in this country. A little bit about what GO2 offers as far as resources. We have a wide range of patient-centered resources that are designed to support individuals at every stage from their lung cancer journey. We have a robust repository online of educational materials, and not just for lung cancer patients, but also all the way from smoking cessation to what is a lung cancer screening to if you've had a lung cancer screening, what does that mean? What do your results mean? What are lung nodules? And then all the way up to diagnosis, staging, survivorship, biomarker testing. All of these resources are available to you and to your families for free. You can go online, search it. If you find something that you like or you'd like to read, you can order it, you can download it. But all of these resources are free to anyone. And a little bit more about what we offer. We have a wide range of patient support services designed to meet people wherever they are in their lung cancer journey. We have a helpline that helps individuals connect with trained staff for guidance on understanding their risk, accessing lung cancer screening, exploring the latest treatment options, including targeted therapies, and learning about molecular testing and clinical trial opportunities. We also offer a Fun Buddy program, which matches patients with survivors who have shared experiences, and we help locate qualified medical centers for early detection, diagnosis, and treatment. So essentially, if you have a diagnosis, you can call into this Fun Buddy program and sort of match with a pen pal that also has experienced something very similar to what you're going through, and they can kind of help walk you through this journey. We also have a lung cancer living room. And I don't know if you can see me, but I have a gnat, so I'm not just squatting at nothing. There's a gnat in my office, and it's driving me crazy. And we also have a lung cancer living room event, and it's held in person and live streamed every third Tuesday of the month. It brings together lung cancer experts, fellow survivors, and caregivers for education, support, and connection. And we also offer some special edition sessions that dive into some very timely topics and emerging discoveries, ensuring that patients and families have access to the most up-to-date knowledge and resources. So that's a lot of information to throw at you, but if you think that you may qualify for lung cancer screening, or you know somebody who might, I put together a little kind of next step, what do we do from here? The first thing that you need to do is contact your primary care doctor and have a discussion with them about risk and benefits and qualifications for lung cancer screening. If they agree with you and you jointly agree that you are a good candidate for screening, they will provide you with an order along with a referral to a screening center if they don't do that at their facility. Next, we have insurance verification and cost overview. I came from a private oncology clinic we had a lung cancer screening program, and we had a prior authorization department who would go through all the patients scheduled for lung cancer screening, check out their insurance, and make sure that insurance covers that screening, and if there are any out-of-pocket costs, that the patient knows about them ahead of time. Not every facility has that, so I always recommend if you want to have a lung cancer screening that you call your insurance and just verify with them that that's something that they do cover and figure out what your out-of-pocket cost is before you go, if there are any. And next, you'll schedule an appointment for screening. There's no preparation needed. There's no IVs. You don't have to get undressed. There's no prep. There's no oral medication, anything to drink, nothing like that. You literally walk in, and it takes more time to get to the facility, get in the scanner than it does to actually do the test. The screening takes about 5 minutes. They take some pictures of your lungs, and you leave with no restrictions. After that, your results will be relayed to you by the provider, and they will schedule your follow-up. There's some variations in this. There's different ways that people do things. Different clinics do things differently. But in a nutshell, this is essentially the path that you'll follow. Most likely that follow-up will be an annual screening, but it depends on findings in that lung cancer screening. Sometimes they may need to see you a little bit more frequently based on what they see on the imaging. And I also wanted to add this. This is a video that we shared at a VA event we did in Kansas City. And I think even though this is a veteran and these kind of the conditions that he was exposed to may not be what you are, but it highlights the urgency and the need to do lung cancer screening should you qualify to detect these things earlier. But I'll play this for you. Let me know if you cannot hear it. Please just break in and tell me if I can't see the chat.
My name is Kenny David Chandler. I live in St. Mary, Missouri. I have been there for 30 years. I do a lot of gardening and stuff like that. Being retired, you've got time to do stuff. You work for it, so you're supposed to enjoy it. I was in the Army. They first had 26 artillery in Germany. Went in March 14, 1968. And the VA got me quite a bit on it, not like that. So you always run to come once a year for a physical. That's how they found out I had a cancer on my left lung. It was that side of the half a penny.
My name is Andrea Cuddy, and I'm the medical director of the lung cancer screening program at the Kansas City VA. This veteran didn't have any idea what lung cancer screening was. And, he went in to establish primary care and immediately identified, we could have done much for lung cancer screening.
Well, lung screening is an easy process. It's quick and painless. It takes longer to get ready to get into than it does to do the work. It's just to lay down on the table, they run you through it, they take the pictures, and the pictures will come back and say, hey, you got the cancer. That's how they found mine.
I felt strongly that we needed to be aggressive in this care. And so we actually came back here for treatment, underwent stereotactic radiation, and within a week, I completed treatment.
Well, I'm glad I did it. I didn't like to make the trip to Kansas City because I'm a country boy. But Dr. Cuddy called me and asked me that. I'll tell you, I'll come out to Kansas City to VA. And she said, ain't no problem with that. She said, it's your house. They pay for everything out there. And the people were great. So now the full radiation treatments and that's all the clerk and said they got it. I mean, I didn't get sick or nothing. I didn't even know what I was doing.
He's a survivor now. He's in our survivorship program, and he gets a CAT scan every 6 months, and we're very hopeful that in 5 years we will return to our survivorship low-dose CT program and they'll be screened every year. Our veterans at higher rates than normal are likely related to their toxic military exposures. They are exposed to silica, asbestos, armpits, Agent Orange, all sorts of things that can increase risk of both emphysema and lung cancer. So to me, it is a moral imperative to deliver something amazing, really deliver excellence in healthcare, and to have that comprehensive program. I didn't go into medicine to do the bare minimum.
I didn't think I'd get rid of lung cancer that easy. Get rid of lung cancer in 3 months. That's a blessing, you know what I'm saying? If the VA were to pay for this, I would not connect with it. So I don't thank the VA for that.
The VA system is creating a comprehensive system to take care of you, to serve you. Please get screened for lung cancer. There are so many people here that believe that your life is worth saving and want to offer you these services if you will come in.
I'm gonna look at it first, and I don't do a lot of money. But I'll tell you, it would help you people, if you can get rid of something like that and keep from getting sick, you better get it all out. So, anytime you do a physical test, if they will do the lung cancer screening, it can save your life.
So I always get choked up when I watch these videos. I texted Angela earlier today while I was looking for a video for this talk, and I said it is 9 a.m. and I can't stop crying because I see these patients, and what really stands out for Mr. Chandler is the fact that he said, I'm a bullheaded person and I don't do a lot of things. So had he not gone and had that lung cancer screening recommended to him, and his cancer not been found at less half of a penny size, his treatment and his outcome would look a lot different. And I guarantee that had he not had that screening, he would not have sought treatment or sought a physician until his symptoms were to where he could not manage those. And at that point, he would have been, a much further staging, could have potentially been metastasized to other areas of his body, and his treatment and his outcome would have been a lot different. So I feel like he really highlights what it means to the importance of having a lung cancer screening and catching that lung cancer early. And at that, I have nothing else to say, so I'm going to stop sharing, and I'm open for discussion and questions.
Thank you so much for coming to our group and showing this. I think that's pretty informative. I did have a question. I had heard that the lung cancer screening, the current or past tobacco use within 15 years, that aspect was taken off. Is that still part of the guidelines? The quit date?
Yes, currently it is. The recommendations have been changed to exclude the 15-year criteria. However, it has not been adapted by insurance companies as of yet to cover that screening without that criteria. And Angela can possibly elaborate on that for sure.
Yes, it's the American Cancer Society and the NCCN clinical guidelines that do not have the 15 years since quit exclusion, but the U.S. Preventive Service Task Force recommendation and the CMS coverage determination for Medicare beneficiaries, both of those do still have the 15 years since quit exclusion. And we have asked, GoTo has submitted a request to the U.S. Preventive Service Task Force and to CMS, asking them to take steps to revise their guidelines. But that is a lengthy process, and neither has said they will do so yet.
Thank you, Angela.
Well, do you guys have any clue on how much it would cost if you were cash price?
If you pay for it yourself.
Yeah, so there are programs that exist out there. Not every screening center offers that. Most follow the CMS and USPSTF guidelines and only screen patients that are eligible. But there are some centers out there that offer out-of-pocket cost and screen outside those guidelines. And I think that varies from the facility that I came from. It was around $130 or so, but that's been a few years ago. And I think that's probably pretty average. But also there are foundations that help patients that can't afford to pay that out-of-pocket cost at many facilities. So it kind of varies, but there are facilities out there that do screen outside the guidelines and offer.
Yeah, I'm just trying to again, I would just recommend that if you are interested, that you contact several of the screening programs in your region and ask them if they do have a low self-pay rate. If they do, to Cindy's point, it could vary anywhere from $125 or $130 to $250 or so, which is about standard. The lower self-pay rate is normally in that range. There are some programs that will allow for people to be screened, but they do not have a low established self-pay rate, and so they will charge you the charge master rate, which is very high. So you definitely want to ask them ahead of time if they have a self-pay low cost option.
And our hope and our wish is that everybody who's high risk for whatever factors, even if it's not the 3 that meet those guidelines, for chemical exposure or whatnot, everybody that is deemed high risk will be eligible for lung cancer screening. I know that's not the case right now, but that is what I would like to see. And I'm sure most people would.
Yeah, we do advocate very strongly for expanded access to lung cancer screening. It's just a long, slow policy change process.
The other question I have is, when did it become that you're promoting the screening? Because my poor dad died of lung cancer in 2001, and there was never any screening options that were discussed with his doctor, yet he was a smoker for 45 years. So this is something new, right? I mean, back when he was diagnosed, it was like, well, you did it to yourself. And there was like very little sympathy. No sympathy.
Yes, unfortunately, that is what we hear a lot. It is relatively new. I think probably 2011, right, Angela? 2011.
It's the NLS2 was published in 2011, which is the National Lung Screening Trial. That is the study, the national randomized control trial that established the effectiveness, proved the effectiveness of low-dose CT lung cancer screening, on which the U.S. Preventive Service Task Force based their first recommendation for lung cancer screening. And that came out at the end of I think it was the end of 2012.
Yes.
Is when it was published. And so the national coverage determination from the Centers for Medicare and Medicaid Services for Medicare beneficiaries came out in January of 2015. And that's right around the time that the U.S. Preventive Service Task Force recommendation went into effect. After they made the recommendation, there was a year of ramping up to begin coverage. So, so 2015 is when the coverage for it began.
But we hear that so much more than, well, I wish we didn't hear it at all, but so much more than it should be, is that there were no screening opportunities for lung cancer, and there's, like I said, the stigma attached to it, and the shame and the guilt of, well, you did this to yourself, so you get what you get. And obviously that is not right.
And I'll just chime back in if I may. When one of Go To the Lung Cancer's predecessor organizations, the Lung Cancer Alliance, was one of the organizations that came forward to ask for coverage from Medicare, for Medicare beneficiaries. And so a member of our staff went to testify on behalf of those seeking Medicare coverage before the MedCAC, which is a coverage committee, if you will, for CMS. And there were experts there who testified against covering lung cancer screening for those at high risk, arguing that it would detract from tobacco cessation, that it would give people perceived permission to continue using combustible tobacco, continue smoking, and therefore there should be no lung cancer screening because it would be detrimental. And thankfully, Medicare did not agree with that and did issue coverage. But in those early days of lung cancer screening, it was a long, hard fight, even to get what we assumed would be certain allies on board behind lung cancer screening. It was a fight because there was this perception that, it's going to be detrimental to the community because it's going to encourage people to continue to smoke, which was incredibly stigmatizing. and demeaning to the population at risk, and further stigmatize it overall, which is just really unfortunate.
What about vaping? They haven't even addressed that, have they?
No, not as of yet. Just talking about, referring to what Angela's timeline was on getting lung cancer screening covered for tobacco usage. There are some studies that are coming up about vaping and the effects of that, but I don't foresee that being a coverage criteria for quite some time.
We still don't have coverage for other types of combustible tobacco. The recommendation is cigarette specific. So it doesn't technically cover cigarillos or cigars or hookah, which many people who use those combustible products are dual users of combustible tobaccos, traditional cigarettes, as well as the other products. But technically speaking, those don't factor into the smoking history. We know that many programs do in fact factor it in, and we believe should do so. But technically, the recommendation is very limited to cigarette only.
I have a question for you.
Yeah.
When you talked about genetic predisposition, are you talking about alpha-1 antitrypsin?
I was generally referencing just any genetic mutation.
Okay.
We're seeing a lot of, younger people with EGFR and other genetic mutations that have been the cause of their lung cancer that don't have any of the other factors. So yes, I was referring to just in general, all of them.
So does that mean that even if somebody did or did not smoke, if they have a genetic mutation that predispositions, they would go ahead and be in the yes, it's okay to screen?
Let me rephrase that so I make sure I understand it. Are you saying that they do not have a tobacco history, but they have a known genetic?
Correct.
Okay, so they would not qualify under lung cancer screening. However, they would qualify for more, insurance, for more close monitoring. If they know they have a genetic predisposition, then they must have seen a genetic counselor or an oncologist or somebody who has done that back work to determine that they have that gene mutation. And so they would be monitored under them, under surveillance under them. So not under lung cancer screening guidelines, but.
So if my son were 52 years old and he only smoked for less than 5 years, but he does qualify with an alpha-1 antitrypsin genetic order, he would not get it through the lung screening program or the smoking?
Correct. It would not be a lung cancer screening smoking history program, but.
But if he told them that he smoked for 15 years, he would be able to?
Yes.
20 years? Okay.
Depending on the volume, so a 20-pack a pack a day for 20, 2 packs a day for 10.
Okay.
Some variation for that.
I know you didn't really authorize that. Okay,
I did not authorize that.
I'm just asking.
But I will tell you that I have been, I directed a lung cancer screening program for a really long time before I came to go to, and yes.
Yeah, okay, great.
And I'll just chime in, and I will say there definitely are physicians who will order a diagnostic chest CT, which is a 71250 diagnostic chest CT, using a low dose protocol for the purpose of getting a baseline view of the lungs to see what's going on. The problem is we don't have the research to guide us in the, understandanding when that sort of screening should begin, at what age, and should it be annual? Can it be every couple of years? There are studies going on right now that will hopefully provide a better path forward for those who have other risk factors, including family history, identified genetic predisposition, et cetera. But they are still in their infancy. There is a study, there's a technology, Sybil, which is an AI technology, where there are several lung cancer screening programs that are part of a consortium that is utilizing this technology to ensure its effectiveness with the idea that it will open up avenues for low-dose CT imaging for other risk factors in a way that is safe for the patient. Because many people will have something in the lungs that could spur an invasive procedure or a whole lot of imaging. That is not cancer, but we don't know that until there's something invasive or until there's a lot more radiation through repetitive imaging. So there is a risk involved with low-dose CT, and that's why we want to make sure we screen the right populations. In the chat, and this is something that you all can pass along, because I know not everyone is part of this virtual world, but I put in the chat a link to one of the research studies going on at GoTo is one of the partners in it. It's called Inherit, and it is looking at the genetic risk for lung cancer. And this is not a screening study. This is just building the body of evidence that we believe will contribute to the knowledge base to help expand access down the road.
Thank you. And piggybacking on that, talking about the potential harms for screening, they are small, but they do exist. And that kind of goes back to that first step in what you do after this, having that shared decision-making visit with your primary care doctor. So together you can look at your risk and your factors and other, your health in general. Are you healthy enough to go through a lung cancer screening? Are you healthy enough, and are you willing to, should that lung cancer screening produce a finding? Are you willing to, and are you healthy enough to go through diagnostic imaging and a biopsy and treatment? So that's a decision that only you and your healthcare provider can make before he sends that referral. So there's a lot of moving parts and pieces to that you really need to discuss. It's not as simple as you meet these boxes of criteria. If you're otherwise unhealthy, say you have COPD and emphysema and you're already on, oxygen 24/7, is this the right step for you? There's just various things that need to be discussed before you go on to screening.
I have another question about the CT scans. So we get a lot of people who come in through the hospital and they get a CT scan in the ER, and it's the same scan looking at the chest, but the radiologist isn't necessarily looking for lung cancer specifically. So do you recommend for those people to get a low-dose CT scan outpatient once they're well, in addition to the scan they've already gotten in the ER that was looking for pulmonary embolism or whatever?
It depends on the findings of that, and if they meet the criteria. So we kind of have two different buckets. We have lung cancer screening for patients that meet the guidelines we talked about, and those nodules that are detected through that pathway. And then we have incidental pulmonary nodules for patients like you just described that show up in the emergency room with chest pain, and they do a chest CT for pulmonary embolus or any of those things, and say that they detect a lung cancer or a lung nodule through that pathway. There are different guidelines for follow-up on both. So it depends on what the imaging shows and their factors, whether they meet the guidelines for lung cancer screening. But should they meet those guidelines for lung cancer screening and they just had a CT of the chest, there's some other factors that insurance won't cover another CT. If that imaging that they had just shows a small nodule that appears to be stable, they won't cover another lung cancer screening for a year, a calendar year. So it depends on what that screening or what that imaging shows.
Right, and I'll just chime in as well. If there is a nodule that is detected incidentally, and in an ideal pathway, and there are more and more programs that are developing these pathways, where a nodule that is identified incidentally, as Cindy said, will be flagged and sent on to ensure that that patient doesn't fall through the cracks. So if they don't meet the criteria for screening, it'll go to an incidental pulmonary nodule program that will then evaluate, is this someone that needs to come back in a year to make sure that this isn't changed, and then we'll come back and then we'll have a diagnostic CT again in a year to see if it's grown or if there's any changes, or if it is too small to warrant follow-up, it is very low risk, and therefore it's not deemed that the benefit further imaging outweighs the risk of more radiation from a follow-up additional CT scan. Or maybe there's something that is more concerning and they want them to see them in another 3 months to image that and see if that nodule has again grown. So in the ideal scenario, and as I said, more and more programs are doing this, there is a pathway whereby these pulmonary nodules are followed up on so that patients don't miss that opportunity for early detection from a nodule that is found outside of lung cancer screening.
Sorry.
I know. And all of this goes to that low screening rate because there are so many caveats to this and there's so many different pathways and you have to meet these guidelines. Oh, but if you meet these guidelines, you also have to do. So this is my personal opinion as to why our lung cancer screening rates are so low because of the confusion and the hoops that you have to jump through to get the screening done.
In my situation, I was diagnosed in 2019 with COPD. And when I was diagnosed, they had me do a CT scan on my lungs. And because I have nodules, I've had one every year after that. But next year is the last year that I will be qualified to have one because I quit smoking. Next year it'll be 15 years. So I quit. After that, then they won't do it anymore.
Yeah. And different programs provide different options for people that either age out of the guidelines or they reach that 15-year criteria. Where I came from, if we felt that further surveillance was necessary, we would code that scan differently as a diagnostic scan versus a screening, just so that we could continue to monitor those nodules. There are some ways around that hard stop from screening. So I would explore those options as well.
Yeah, sadly, that does come with a cost, unlike what should be in place for a screening, which would be covered fully as a preventive service. Unfortunately, when it's the diagnostic pathway, that's when the cost arises. But if it is coded as diagnostic, then you would meet if you have a copay, you meet the deductible, or there's the potential to explore the low self-pay rate that we were discussing earlier if a program has that. And hopefully, there will be options in your area for that.
Got it.
Now that I have thoroughly confused everyone in the room, I'm sorry that it's such it's a hard subject. There's a lot to it, but we are always here. If you have any questions, feel free to reach out. I'll drop my email in the chat. You are always welcome to reach out to me if you have any questions. If I don't know the answer, I can help find them.
Yeah, you guys have a great website with a lot of information on it. So I printed just one of the little handbooks to hand out here. And I've handed out your brochures before, so that's really helpful.
Awesome. You can order those. You can print them. You can download them and print them as PDF, or you can order them in bulk. Should you find that there's a need for them in your area, you can order them and pass them out. Whatever you need. And if you see a need for education documents that are not available, if you see a need for something, please let us know because we have excellent people. We have a whole team dedicated to developing those education pieces.
That's awesome. Thank you for coming. And I'll make sure that Ray hand out your resources that you put in the chat, and I'll send it in the email to the rest of the people who couldn't make it here today.
Thank you very much.
Sorry, I got a bus and now my dog is. Okay. to meet you guys. Please reach out to me if you have any questions.
Thanks.
Okay, thank you.
These things are cool. Nobody showed me this before.
That's really cool.
Literally every time.